and sends her apologies. Before we begin, I'd like to draw everyone's attention to the following points. First, this hearing is being streamed live and will be recorded. The recording and transcript will be published afterwards on the state's website. Second, for those in the room, all electronic devices should be switched to silent. Third, I also want to make clear that the aim of the hearing is to listen to the experiences of our three witnesses and note any lessons learnt that could be used to improve the health service. The hearings will not be discussing any individual employment matters. Finally, before we get going, I'm going to ask my fellow panel members to introduce themselves. So starting on my right.
Deputy Philip Balash.
And Deputy Lucy Stevenson.
Good. So our contributor is Tom Hayhoe, who was appointed as the first substantive chair of the Health and Community Services Board, I think at the very end of February. He left the following month by agreement with the Health Minister. And I thought perhaps we could start, Mr. Hayhoe, if you tell us a little bit about your experience as it relates to running boards and driving improvements in healthcare.
Right, well, I've chaired boards in the public sector, private sector, third sector, and for that matter, hybrid boards with which are a mix of public and private sector in the UK for many years. My first career was in the private sector as a management consultant with McKinsey and Company, and then as a retailer. But having studied health policy and economics while I was doing my MBA at Stanford back in the late 70s, in the midst of time, I've had an involvement sitting on boards in the NHS and in the healthcare space, actually going back to 1985, alongside the private sector career that I had. And then moved progressively as we got into the sort of new century, increasingly into healthcare, both in the private sector and chairing two NHS trusts. I also sat on the advisory board for NHS Improvement and NHS England and for the Care Quality Commission, and chaired a regional committee making merit awards for the most senior NHS consultants. I've also had 10 years working in professional regulations alongside the other things I was doing. First with for nurses and midwives, for chartered accountants, and for tax advisors. And these days, I chair the Legal Services Consumer Panel, which advises the Legal Services Board, the legal service regulators, and the Lord Chancellor on matters relating to the consumer interest.
Okay.
So that, I think, gives you a sort of full profile in terms of background. And I think things which are of relevance to the appointment that I briefly had in Jersey.
So you didn't spend long here, but I wonder if I could wind you back a little bit to when you were applying to work here. It was obviously in the wake of the Maskey-Taylor report, and I wondered what your impressions were, your first impressions were when you came to Jersey in the light of that report.
Well, I think the things which I had to get my head around, first of all, is that Jersey is a small and proud nation, which consequently, not because of its independence or its size, but or its pride, but it does face some big challenges, being serving a population of 100,000, which is sort of way below sort of critical mass for all sorts of clinical services. And just by way of illustration, we were when I was at West Middlesex Hospital, we took over the maternity services from Ealing Hospital, which was in many respects viewed as being subscale, consequently not very safe, with the consequence that mums were sort of, voting with their feet and going elsewhere, which was operating at the level, if I recall, of maybe around 2,000 or 3,000 deliveries a year, getting on for sort of 4 times the number of deliveries that there are on the island, and that just creates challenges being a relatively small place. The other thing which is really striking is that there are certain aspects of the way that healthcare is delivered in Jersey, which you employ, or it's not part of HCS, twice as many GPs per head of population as we have in the UK. Now, that's not necessarily on its own is a bad thing, but it reflects and it actually represents some of the opportunities you face and the fact you are as generously doctored as you are. Coming into post, there were, and I'd read the Maskey-Taylor report, I'd read some of the other investigations from Royal Colleges over the years. I was acutely conscious that I was coming into a service which, on the face of it at least, has some major issues facing it around patient safety. And that has been a major concern of mine for many years. There are clearly, and this sort of did strike me over the relatively short time I was with you, some issues surrounding culture within HCS. By the standards of modern healthcare, massively hierarchical, with, dare I say it, insufficient respect for the
professions
outside medicine itself.
And what do you? Sorry, excuse me, Tom. What do you mean by that? Insufficient respect for professions outside?
Well, I think that it is the sense I've received from nurses, pharmacists, and I know there were some very tricky issues in pharmacy, from therapists, is that they were not accorded the respect that I would from partly from doctors in terms of where they sort of sit in the hierarchy, and it does feel to me like a service which, in many respects, it feels much more like the service I first started getting involved with in a professional capacity back in the 1980s, as opposed to what I would expect to see in terms of modern medicine.
What were the particular outliers, if you like? You've obviously got experience in many different health settings and regulatory settings. What were the things that struck you as outliers in Jersey compared to what you would consider the norm?
Well, if we were to look at there are some issues, for example, and I only had the opportunity to attend one because of the length of time I was there. The sort of it's kind of atmosphere comments that came across in the medical staff committee, which is the sort of consultants committee. There were some other things which I think related to the degree of responsibility and autonomy given to people outside the medical professions, whereas the expectation in medicine was actually that the doctor was king, as opposed to a professional with a particular sort of skill set. So I think that's probably the issue that's in there, and yeah, I think that's probably what I would want to capture there, and also just didn't have a sense, and again, I wasn't on the island for very long, of the sort of respect for the sorts of things which, in fact, and Hugo mentioned them in his report, which add up to kind of good clinical governance. Things like attitudes to medical appraisal, and one of the things that the GMC requires in the UK these days is that there's some lay involvement in medical appraisal. So I spent some years rolling my sleeves up and being involved personally in medical appraisal. But there was a sense, and some of this is hearsay, but this is hearsay from the doctors, about the degree of that more than lip service was paid to those sorts of things. And that, if one's looking at trying to create a culture of patient safety, is an important thing. And it applies to all professionals, actually, the importance of high quality appraisal, feedback, adherence to standards of continuous professional development. And I think alongside that, the other thing that struck me just looking at the raw data, and this is something I've been pretty passionate about for many years, was having a culture in which it is okay to report clinical incidents and safety incidents, and above all, actually, not just the things that actually happen, but the near misses. My sense was that coming into it was an appetite, and the convention was cover up rather than saying, actually, look, something's gone wrong here. What are we going to do about it? And what, to the extent that this has been an issue in healthcare, not just in the UK but elsewhere, that the tendency is for people to try and, well, let's pretend that didn't happen, as opposed to say, look, actually, the surgeon on this case, and this is a hypothetical example, not to do with Jersey, very nearly cut the wrong leg off. And had it not been for the scrub nurse sort of saying, I'm sorry, Mr. So-and-so, that actually we're operating on the right leg, not the left leg. That it's important to report the near miss and learn from it. Jersey, if I recall from looking at the data, has a relatively low level of incident reporting. If you look at industries like nuclear power, aviation, to name two industries where, after some very high-profile disasters, the standards of safety management are many ways set the benchmark for other industries. High levels of incident reporting are viewed as being a good thing, as opposed to something that you feel vulnerable about reporting. Whistleblowing is viewed as being a healthy sign, and that you approach it in a culture of continuous learning. Now, that is not something that came across to me from my assorted meetings, albeit over a relatively short period, in HCS in Jersey.
You say you read the Maskey-Taylor report before you came. Obviously, some time had elapsed after that report had been written before you arrived. Was your impression that either management or politically, these issues were being grappled with and addressed effectively, or was your impression that there was still an awful long way to go?
Well, I think the most important bit of progress was actually recognising, which is a clear political decision, that something had to change, and the establishment of the advisory board. Now, I think as it's turned out, and it's in the public domain that not everyone was convinced that the advisory, that introducing a more robust government and independent governance structure was the way ahead. That my sense is that it hasn't been given the opportunity to really rise as it might do. So yes, big tick for recognising that something had to be done, but I would be very anxious that, and there were some initiatives that I had tried to set in motion to try and improve the input from the widest range of sources possible to inform the decisions of that board, and also make sure that the board kind of was engaging with both the patients and community, and with the clinicians from all professions throughout the organisation. So it feels, I wouldn't say stillborn, but it hasn't. And given that my understanding is that it's about how the board is operating now, without a substantive chair, without a full complement of non-executive directors, that it's not. And for example, some of the things that I had proposed shortly before, I decided that there wasn't really a basis for going forward in the role. That haven't been sort of put in place. So I think that's the. I think the thing which had been was in place was that some good people had been brought in to work and try and support and address some of the identified shortcomings in the service. Some of the interim appointments and consultants who are working alongside the service were, seem to be doing some very good work. So, for example, things like trying to address that issue of a safety culture and make people more comfortable with incident reporting were being pursued by that. By the people who are working with to support HCS, and alongside that, because one of the issues is there's some most organisations can find ways of improving the way they operate to improve quality, to improve efficiency, release resources which are being not as well used as they might be for other purposes. And one of the things which was very clear was that the HCS had moved to a position where it was, I think the running deficit was of the order of 10% a year. Now, there's nothing unique about that. There are hospitals in the UK which have got operating deficits at that sort of level. But given the relatively generous levels of resourcing of healthcare in HCS in terms of cash, which to some extent are necessary because of the lack of economies of scale, it was clearly important that people were looking at ways to do things better, which may be improving objective quality, but equally well maybe a matter of sort of saying, can we actually save money here by doing this a bit better, which releases resource for doing other things.
Beyond the governance issues, were there issues around, I don't know, the balance between private and public healthcare? Were there, you've hinted at issues around money and so on. What other things spiked for you as things that needed to be looked at?
I think one of the things which desperately needs to be looked at is how pharmacy is funded. And so you've got this issue about who pays for prescriptions in community pharmacy against what happens in the hospitals, which results in it contributes things like costs which in other environments will be much better, or services will be much better delivered in community pharmacy coming back to the hospital. I think in terms of one of the really glaring challenges that the organisation faces, and I understand some of the sensitivities, and people feel very, appreciate some of the ways in which primary care operates, partly because there are quite so many GPs on the island, is that the nature of the sort of the fee-for-service model in primary care and the relative cost of it means that there is significant, I've described as inappropriate, but sort of care that should be taking place in primary and community care ends up being addressed in the emergency department, because it doesn't cost you to attend the emergency department, whereas it does if you attend your GP. And looking forward strategically for Jersey, I think you've got some really big wider policy issues to consider, is whether the current model is an appropriate model for a very rapidly aging population, where the risk is that activity takes place in hospital rather than being addressed through a sort of preventative agenda in primary care. And at one level, and I've used the words that actually the numbers of GPs on the island represent Jersey's kind of get out of jail card, in that you have the doctors there, which is a contrast to the picture we've got in the UK, but that the model needs to be moved away from quite the degree to which it's a fee-for-service model, to one where it's more about a sort of I'm trying to use a sort of commercial metaphor, because you have a very commercial relationships in primary care, where you have an annual care contract with your GP, which means that you create the incentives around preventative care, around the regular monitoring, where actually in primary care you may end up with something of a shift in model. So there's more input under the direction of the GP, from physiotherapists, from community pharmacy. The classic problem you find with older people, and which I might count myself sadly, where you end up with a problem which is known as polypharmacy, which is that you lose track of quite the number of medications that your patient is on, because you pile one on top of the other, and you need to then review, actually, should we be, there are potential problems with patient X being on these 3 medications, and we may need to look at moving from one to another. And that's something which, in well-run primary care, so my local practice, in which a patient in Hammersmith directly employs a pharmacist who's not there as a dispensing pharmacist, but uses her skills to assess, to actually to manage things like the repeat prescriptions reviews, but also regular reviews with patients, whether or not, given the other medications they're on or how their healthcare is evolving, we should take you off medication X and maybe replace it with medication Y, because of the problems it has with medications A, B, and C that you also take. So there's something about changing. Jersey needs to think strategically about how it changes its overall healthcare model. And alongside that, I think that then raises questions as to what is handled in primary care, how the relationships then work with the hospital. And if I look at the vexed issue, I know that this is one which has been running for a lifetime, about the reprovision of the acute hospital. I'm not sure, and I'm not suggesting for one moment that, given where you are, that you should tear it all up and start it all over again. But that if you were starting from scratch today, you'd say, do we need a hospital which has the number of beds we're putting in place? And because actually we should be doing more in terms of supporting the patients in the community, guided by primary care, not least because actually that's what, certainly in my experience, patients want to be looked after in the community setting, and hospitals are not, a lot of conditions, the right places for patients to be.
Have you got
I wonder if we could go back to the board for a moment, and given your experience over many years on different boards, how do you see a board like this working effectively, what should its relationship be with the different parts of the health service, and are we achieving that at the moment?
Well, I think that one of the challenges with this, of course, is that the board itself, as currently constituted, is an advisory board rather than a classic corporate governance board. So, but with that caveat out of the way, my sense of the way in which you ought to be developing health and care services in Jersey is to look to have a board that has a responsibility for all the parts of the healthcare, the health and social care system, and that would include the social care system as well as the hospital, but also oversight of primary care and pharmacy. There are two very different roles between running an executive board to run a small acute hospital. What the appropriate model is for running, if you were trying to run just the mental health services, or for that matter, have oversight of community care. One of the things that attracted me to this role was that the fact it did, at least, even if it didn't have oversight of primary care and community pharmacy, did bring mental health and acute services under one sort of virtual roof, and also social care, because a lot of the issues that we see in the UK around the challenges of discharging patients from hospital are to do with the social care provision that you provide for someone when they, and again, I'm not suggesting that you have a fairly rich community of care homes on the island, I understand, but there's at least able to kind of pull together the various strands and facilitate when a patient, say an elderly patient who might say have had a stroke or some other condition which has meant that there's a step change in their care needs on discharge, that someone's able to sort of pull that together. And similar issues that can arise when you are discharging someone from a mental health setting is you will need to make sure there's appropriate sort of social care as well as continuing mental health care for someone being discharged after an inpatient episode. So, if I was to, given the free hand to design a healthcare governance system, it would be one that had a broader remit than the current board, and actively pull things together. So, we've moved in the UK, albeit that it's a case that there isn't a consistent model to the introduction of integrated care boards, which is, I think, an appropriate move in terms of direction of travel. Now, we're talking for an integrated care board in the UK about populations on my patch that 20 times the size of Jersey. But the ethos of trying to be able to have sight of the whole system and address levers that mean that the incentives are appropriate and the relationships are appropriate is something that, if you're looking to where you go in future in Jersey, would be something I would encourage.
Should the senior leadership team in the hospital have some measure of accountability then to what we call the advisory board?
So is that that was a sort of statement? Yes, they do have an accountant.
Well, it's a
my
no.
understanding
It was a.
They were accountable to them, but one of the interesting things is it's in the name. It was, and that it is explicitly described as an advisory board. Now that doesn't. Now there's an executive structure which is in place, it is really not clear when something is given the title of advisory board, whether it is there to advise, in which case, who is it advising, and as opposed to being accountable for a budget, being accountable for the standards of service that are delivered. And so in terms of the board structure, my feeling, and I tried to work with it, and to some extent, took the view that there was an accountability to the board, and the board itself was accountable. But I think there is a severe confusion in the what, if I understand it, was viewed as a kind of compromise outcome, which, when it was designated, rather than, as Hugo had suggested, being a board which is accountable for an organisation, and having spent a lifetime in governance in a whole wide variety of contexts, and contributed to the evolution of governance models in the UK in the corporate sector as well as the private sector, it feels like a governance model. No, I can't find the right metaphor for it, but it is not a satisfactory model, one that you've got in place. It is clear that something needs to be in place. I think the recognition that there was merit from, in a sense, separating delivery, which is what it's there to do, but what the board should be there to do, from policy, which is what politicians are there to address, was a missed opportunity or a mistake. And one of the problems you've got is that the board is due to be reviewed in March next year, if I understand. But there was a sort of 18-month review point. I don't see how it would be possible to view this as having been the current exact models being appropriately delivered when it's being, it doesn't have a substantive chair, it doesn't have an appropriate quorum of non-executive directors. I haven't followed things closely enough, but I'm assuming that there still isn't a sort of financially qualified audit chair type person in place on the board, which had always been the intention. And so I think there is a case of saying, look, actually, Jersey should consider reviewing whether it should go back a stage and say, actually, the advisory board notion was a mistake because it creates a huge confusion as to what the role was. It does then depend on, it's going to be an advisory board. You need to expect it to provide advice, and I think I don't think it's a matter of I'm sort of straying too far in terms of the kind of employment issue, but there was a difference of view as to what the role was, the role of the chair of advisory board was between me and the minister. And I think that's something which needs to be clarified if you're going to put in place governance for healthcare, whether it is on the current boundaries or whether it's on the wider sort of integrated, fully integrated model I described. That I think that is something that you do need to give some very serious consideration to.
In terms of the financially qualified board member, it's my understanding that there's still been a search on. Did you have any involvement in that? Why the struggle to find somebody to take up that role?
Well, it was described to me that initially there had been, there is no shortage of people who are financially qualified and very capable people on the island. It's something which I've heard somewhere or other that Jersey's actually quite good at. Wearing chairing the tax advisory board, tax disciplinary boards in the UK, we're very conscious of the fact that there are lots of things go on financially in Jersey, precisely attract very good people there. Now, one of the things that had been described to me is that when there was initially a search, that no one on the island, this is going back into last year, from the financial community who viewed this as being something to which they felt that HCS was a sufficiently complex and difficult set of problems that they were not inclined to engage with it and say that I'll put in my couple of days a month to trying to do my bit for the Jersey community, deploying my my financial knowledge and expertise. And so when I arrived, that was a post that remained vacant. My understanding, albeit I wasn't there for very long, was that there were people who were identified who felt that the changes which were in place and what little had been seen of me in your very extensive and very rich local media suggested actually this might be something which they would be willing to do. And I think one of the things which is desperately needed on that board is more people who are from the island. I think it's and there must be, while I think of good reasons for looking further afield for a chair and maybe one or two of the members of the board from the island, I find it extraordinary actually that it was not possible. And I don't understand what the reasons were.
But Tom, can I just interrupt just in terms of Lucy's question? You said that people didn't come forward from the finance community. Were you given any indication as to why that was? What was it that they didn't like about the job?
I think that they felt that the word used by one person who described it, they felt that HCS was a basket case and that they didn't feel it was going to, they didn't want to be sort of tainted by being part of something which was, a sort of failing organisation. Now, I think there was a sense that there's some very warm media coverage when I was first appointed, and people felt that things were turning, that there was a sense that maybe it might be different if they went out and tried again. Now, that's merely hearsay. But I think there needs to be some sort of sense that this isn't, that it's a really important job to be done, that there is a major contribution, positive contribution to be made. That one of the things that does, I do wonder about, we haven't got that far with the process for the of initiating a fresh recruitment round for a finance person while I was there. But my understanding is that Hugo, as the interim chair, wasn't involved in any way whatsoever and was actually explicitly excluded from any from the recruitment of the non-executives for the board. And I think there's something about, I certainly wouldn't expect to find that when recruiting for any board that I've been chair of in the past. In that while the decision might still formally, in terms of good sort of public sector governance, be handled by the Jersey Appointments Board, that you would expect the chair to be involved in the recruitment process and probably be in a position to veto a candidate if they felt they were inappropriate, even if the ultimate decision was with, in your case, the Jersey Appointments Board.
If we move just to one other area, what did you form any views about the relationship that HCS might have with UK centres in terms of how the care might be provided, how much should be done on island, how much might be done off island? Did you take a view on that, or was that not something that you had time to dive into?
Well, it's certainly something I gave quite a lot of thought to because, albeit I was wasn't there very long and was quite keen to use some of my network and relationships to open things up a bit. My sense is that Jersey has to take some really difficult decisions about what things are done on island, what things are done off island, and ensure that there is some real integration between services which are delivered on the island where there may be a need to escalate. I think there are also issues if we look at things like clinical governance and the oversight of services, and where there should be the UK is the obvious one because it's of the issues of language and similarity. But if it was possible to do it with France as being the very near neighbour, I couldn't see a good reason for not doing that either. But that I would expect, if in an ideal world, I would like to see the clinical leaders on the island, and here I'm talking explicitly about consultants, regularly spending a month on exchange with a clinician in another UK hospital, probably partly because it would help to keep them abreast of good practice. And actually, if part of it was that there was a backfill with, and it literally was an exchange, that say someone from Southampton came to do a month on the island while a consultant from the island was doing a spell in Southampton, would be that the teams they were working with would also benefit from that sharing of experience. I think there are some very big issues, and without needing to go into how the problems with rheumatology blew up, that really good peer review, exposure to good practice, both bringing people onto the island as well as people getting off the island to do it, are the sorts of things that you need to do if you want to develop a service which, for a nation which on some welfare measures, I think, comes second only to Zurich in terms of places which should be desirable to live with high levels of income and good quality service. You don't have it in healthcare, but you really ought to be in a position to do it. But it would involve having some partnering arrangements with areas where really top-notch healthcare is being delivered.
Do you have a view on whether that is better done in terms of a single institution, or whether it's capable of being equally well done by consultants having their own, as it were, ad hoc relationships with different hospitals in Oxford, Cambridge, London, or wherever?
I would probably, given the scale of things, suggest it would be best done with a relationship with probably one, but it might be in terms of, somewhere of the scale of somewhere like Southampton University, or for that matter, it might be one of the big London trusts. And I think the issues about, there are all sorts of challenging issues if you were the partner organisation, because I'm thinking about Imperial College Healthcare Trust looking after the patch, or is the kind of the big beast on the local patch that I've got, where, just by way of illustration, when I was at West Middlesex, chairing West Middlesex Hospital, we had quite a number of consultants who would have a joint contract between ourselves and Imperial. And in terms of professional networks, they've got those things. I suspect with that the only sensible way of doing it would be to partner with a well-run, large university institution in the UK, where you've actually got people who get exposure to the sorts of things that my colleagues erstwhile colleagues at West Middlesex would have had with their colleagues at Imperial. And it also would mean, in terms of things like medical appraisal, is that you would be able to get input as to sort of say, is Mr. So-and-so or Dr. So-and-so, how are they doing when they were working with us, input from peer group, or for that matter from senior members of other clinical professions, as well as simply getting feedback from their presence on the island. It's a really big, Jersey is at a very interesting position, that it's big enough to have what everyone would recognise as a sort of proper hospital with a reasonably full range of services for all but the more complex activities, but not really big enough to be able to get the benefits that you would have if you were an island with a population 10 times the size.
In terms of the balance between private and public healthcare, Jersey has high levels of private health insurance, although it's not used as much as it could be potentially. Did you form any views about that balance between private and public healthcare and how it might develop going forward?
Well, I came to the island with a pretty agnostic view about how you manage between private and public models. One of the challenges is that inevitably, when you the public model ends up dealing with the problems of the acute emergency and for the elderly and for people on lower incomes. Having spent my early years studying healthcare in the States, one of the things which is Americans are always a bit embarrassed about when you point it out is that actually there's more public money in absolute dollar terms spent per head by public agencies, Veterans Administration, Medicare, Medicaid, and so on, because of the enormous inefficiencies which are built into the US private healthcare model, which ends up being picked up largely by employers, and where decent health insurance is a sense of precondition of employment. In Jersey's case, I think that with an affluent population who are able to, many of whom can afford to make the choices about the sort of the things that you might not choose to provide in terms of the public care, I would expect to see a higher degree of, even if we had a UK model in Jersey, you'd have a bigger private sector component there. However, if I was living on the island with the means or the insurance policy for anything, with any sort of acute health need, routine like a hip replacement is one thing, but anything more complex, I'm afraid I would go off the island. There's a question about, there's a bit of a belief in the island that we've got world-class medicine. I'm afraid if I look at compare at least the paper qualifications and records of clinicians in Jersey to the sorts of people that I was seeing at on the Advisory Committee for Clinical Excellence Awards, I doubt whether no one I can think of who would be in that the class of care that would be getting those the sort of merit awards that the NHS dishes out to the best and the brightest. And that's not a criticism of anyone working on the island. It's just that if you're not around that leading edge care, that you're not going to be seeing and developing and be able to provide those sort of guarantees of the quality that you might get, say, if you were, I don't know, if I was needing a hip revision because my first hip operation needed redoing for some reason or other, I go to the Royal National Orthopaedic Hospital at Stanmore. I wouldn't go to my local DGH, and that's what people do if they've got, if they've got private healthcare.
Without needing to go to the extreme of the example of like rheumatology reviews, how do you start to raise those standards?
Well, I think one of the thoughts is that is the approach that I suggested around partnering with a major academic hospital group. Like I mentioned Southampton because there are planes that that fly into Southampton International regularly, but equally well it could be somewhere close to Heathrow, just in terms of kind of convenience. But because I think that things like that sort of exchange that someone does 1 month a year in a partner hospital, and likewise you have people taking responsibility the other way and coming into the island to provide care, and that sort of benchmarking. I believe, actually, talking to one of the regional directors in the NHS that there had been sort of openings or discussions, exploratory discussions of that sort coming outbound from here on occasions in the past, but they didn't come to anything, and I just don't know enough about the details to know how much substance there was. But I think there would be, I suspect, approached with appropriately. There would be a prospect, I think, of someone being able to reach some sort of arrangement of that sort. But it would also, and depend on the consultants themselves in Jersey being willing to engage with that process. And my impression was that, while certainly there would be some who might welcome it, there would be others who would find it, would be resistant to change on that sort of scale.
Is adopting NICE guidance across the board all part of that as well?
Absolutely. No, I think that I cannot think of good reasons for not adopting NICE guidance. And, occasionally, NICE guidance might be a year behind, real leading edge practice. So there is a justify, or a comply or justify. So if it was because someone sort of said, look, I'm not following NICE guidance here because there have been these 2 really good papers which have just come out of Johns Hopkins or the Mayo Clinic, and I know that there are people doing reviews of it. But again, that's a question about having a decent sort of medical ethics surrounding that. But I would have said that for a small hospital that I remember vividly, actually, where we took exactly that line when I was at West Middlesex Hospital around with our orthopaedic surgeons, who were actually were not following NICE guidance in relation to use of a particular sort of preparation for the skin before going through an operation, and on the view that they knew better. As it turned out, we were getting slightly higher infection rates, which, while not directly attributable to that, but they were certainly unable to say, we want to use preparation X rather than preparation Y. So we had a chief executive starting her life actually as a scrub nurse, and so was able to see down any orthopedic surgeon. But that was an example where we took exactly that view. And it's one thing being with an academically strong research team in a big university hospital, or having something really exceptional. So at Broadmoor, where I was, which was part of West London NHS Trust, whereas you'd understand we had some really exceptional cases in terms of the nature of some people's mental illness. We would be doing things which are an exception to the British National Formulary in terms of medication. But in each case, there was very strong medical ethics around it in terms of the justification for why the medications in those cases were different. And in terms of the patient group we were talking about, these were 2 of the 600, so 3 similar high secure hospitals, most damaged and most dangerous men in the mental health system. But that's not where Jersey is. I would have thought it would be I cannot conceive of a good reason why you wouldn't insist on NICE guidance, and a departure from it would represent, I think, raise serious questions about the safety of someone's practice.
We've only got a couple of minutes left. I wanted to ask you about funding, because it's a hot topic in the island at the moment. I mean, the health system is running at 10%, is basically wanting 10% more on its budget. I just wondered whether you felt the system was well funded, or whether there was a problem with efficiency. Where did that balance lie? Does it need more money, or does it need it to get its act together in terms of efficiency?
I think there's a question about what you do to get for HCS to get its act together. So if additional funds were made available, I think they would need to be put in place against a very clear programme of change, because you do have a hospital which is, I wouldn't say falling down, would be unfair, but it's long past its best by date.
Good. Any other questions? Is there anything else that you feel you haven't had a chance to talk about?
No, I think we've probably covered an awful lot of ground there. There are, I really wish HCS and its people well. I think I did have a real sense of a challenge in terms of morale in the organisation. And it would be nice for it to feel that it was on a path towards success, as opposed to, caught up in I think a bit of a political quagmire, which is, I think, where is the sense I've got. It's not helpful when it feels like it's a bit of a political football, but it's. You've got a challenge on your hands, and I think some of the issues are some quite big structural things, as well as how do you get from A to B, over the next few months.
Well, thank you very much indeed. I think we can stop there. Very much appreciate you taking the time to talk to us, and thank you again. We look forward to seeing how we can get on with this, really.
I will certainly watch with interest from afar.
Thank you very much indeed.
Okay.
Thank you.
Bye-bye.
Bye. Can we stop the thing there? Brilliant. Thank you very much.